Hi, everyone. I'm now going to make a presentation on chronic kidney disease, and I'm going to frame this presentation in a very clinical, case-based manner. And this is the story of my 78-year-old patient. These are my disclosures. So here's the case history. This is a 78-year-old African-American man with a history of type 2 diabetes and hypertension. He's noted to have a serum creatinine of 1.32 milligram per deciliter and an EGFR of greater than 60 mils per minute per 1.73 meters squared. He's otherwise healthy. He has a past history of hypertension, approximately 15 years duration, type 2 diabetes for about 8 years, hypercholesterolemia that's been treated with atorvastatin. His blood pressure is in the 150 to 160 millimeters of mercury range. That's the systolic blood pressure. And he's taking the following medications: lisinopril, aspirin, hydrochlorothiazide, digoxin, metformin, and glipizide. The past medical history, as we discussed, I shared with you of hypertension, diabetes, but in the physical exam, his blood pressure in your office is 152/68, a heart rate of 72. His weight at 120 kilograms, but the rest of the examination is unremarkable. You do some lab values. A dipstick urinalysis shows a specific gravity of 1015, a pH of 6. He's got trace to 1 plus albumin on dipstick, but the rest of the dipstick is negative. His BUN is 28, and his serum creatinine is 1.32 milligram per deciliter, and he has a hemoglobin A1C of 7.8. So the first question to really ask in this case is, does he have kidney disease? His estimated GFR is greater than 60, but his creatinine is 1.32. And this is an important question because as a primary care physician, you're going to see a fair number of these types of patients. Patients who are elderly, creatinine is a little elevated, estimated GFR is normal or near normal. And the question is, what do you do with this type of patient? So the first message that I want to share with you is we don't want to call something a disease when it isn't one. So here is a study that was performed by Lindman and colleagues, published in the Journal of American Geriatric Society in 1985, and they plotted kidney function based on clearance, GFR, not creatinine clearance, but on GFR measured directly. And what they showed over age in this cross-sectional study is that as one gets older, on balance, GFR goes down. There's a progressive decline in GFR of about 1 mil per minute per 1.73 meters squared per year. And so you see here in your 20s to around your 40s, you have pretty stable GFR. And then after your mid 40s into your 50s, there is a insidious decline in GFR that has been attributed to healthy aging. Now, it's different among men and women. So on the right-hand side of your screen, you see normal men and normal women. And you see that in men, the GFR decline starts a little early in one's 40s, whereas in women, the GFR starts in one's 50s. Also, the steepness of the decline in GFR seems to be a bit more steep in men as compared to women. Where does this man fall? You see he falls right on the edge here. So for a person of his age, 78, a GFR in the 60s, estimated GFR in the 60s, with a serum creatinine 1.32 is just about on the outer edges of the lower limit, normal limits for that age. So the likelihood is, regardless of his history, he's going to be very much in the domain of someone who has chronic kidney disease. Now, the next thing to think about is, does he have risk factors for CKD? And this is a list from Andrew Levy and colleagues published in the Annals of Internal Medicine many years ago. And these are the traditional susceptibility risk factors for CKD. Top of the list is these: hypertension, older age, family history of CKD, racial or ethnic minority, and then other factors that have been that are associated with. There's some level of causality that's also been in the risk of kidney failure is not uniform. Relative risk factor compared to whites is shown here. And so the fact that he's Black or African American, he has a 4.5 fold higher risk of kidney disease than a white American. This is because of an ApoL1 mutation that increases the risk of kidney disease among Black Americans. Native Americans also have an increased risk, 3.6-fold higher risk, and Asians 1.6-fold higher risk. So he is in the group of people where a serum creatinine 1.32, a GFR in and around 60 would qualify for being kidney disease. He's at risk. The next thing you might do is to obtain some laboratory data. We've got a dipstick of urine, which shows that he has some low-level albuminuria. But if you look at his urine, these are these broad casts, hyaline casts that are seen, and they're broad because the tubules are a little dilated. And so this individual has again another manifestation of potential kidney disease. You look at his urine closely, there are these waxy casts, these broad casts with little fissures. Again, something that you quite often see in either normal people or people with mild abnormal kidney function. You'll do an ultrasound if you refer the patient, and you look for cortical thinning. Patients with chronic kidney disease not only have smaller kidneys, smaller for their body size, have cortical thinning, and that'll be reported. Just another sign that this person might have chronic kidney disease. You evaluate albuminuria. There are two things you need to remember with albuminuria. One is whether it falls into the microalbuminuria or macroalbuminuria range. Albuminuria would be up to between 30 to 300 milligrams of albumin per gram of creatinine. Macroalbuminuria is greater than 300 milligrams per gram of creatinine. Patients with macroalbuminuria tend to be higher risk than this red zone, whereas those with microalbuminuria in this yellow zone. This patient probably falls in this zone here, where he has just a little bit of albumin in the urine. Detectable when it's detectable in the urine sediment, you're probably somewhere between 30 to 300 milligrams. Albuminuria is a risk factor for progression of cardiovascular disease, as shown in this figure here, at any stage of kidney disease. So it's worth actually measuring albumin in the urine. You can do it very easily by doing a spot albumin to creatinine ratio. You evaluate the risk of kidney failure. I do this in many of my patients, just like cardiologists are now evaluating the risk of heart disease using the Reynolds equation or the Framingham heart equation. We have a kidney failure risk equation, KFRE. This was work was done by Tangri, and it's an equation that predicts CKD progression. And in fact, it accurately predicts CKD stages from 3 to 5 over 5 years. Most people use the 4-variable KFRE. You can look this, just put a Google search term in there of KFRE, and you'll come across the calculator. It's available for free. You enter age, sex, eGFR, and albumin creatinine ratio, and it'll tell you what the 5-year risk is of progression of kidney disease for this patient. If you want to read more about it, published in JAMA in 2011 and again in 2016. This paper that came out in 2019 is a UK study based in community practices and primary healthcare practices. And they made the point from this study that the KFRE equation actually can be validated in different cohorts around the world, and it's a valid indicator of progression of kidney disease. So it's actually worth doing or assessing the KFRE for your patients who you might be seeing to judge what's the likelihood that this person will progress to kidney failure in the next 5 years, or in fact, you can even predict up to 10 years. In many patients, the rate of decline in kidney function is variable. People, as we discussed, who are undergoing normal aging, whether you're male or female, are going to start to decline kidney function somewhere between 45 and 55, and then it sort of declines 1 ml per minute per year. That's a normal rate. In people who are progressing fast, who have a lot of albumin in the urine, who have a number of risk factors, the progression rate might be quite high, 3 to 5 mils per minute per year. And really, one of the reasons you might want to refer a patient to a nephrologist is for them to help you try to flatten this curve. After all, nobody wants their patient to progress quickly over just a few years to kidney failure. And so anything that you can do, any maneuvers, both therapeutic and lifestyle, that can adjust this patient's curve from the steep curve up to a more flatter curve would be good. And in this paper by Collister, you can see again, yes, you get this decline, but what Collister, the point that Collister made, and which Tangri and others have also reinforced, is that kidney function decline is not linear as many people think. Some people, you can get stable creatinine, some people get mild decline. In others, you can get a decline and then a flattening. So keep in mind that you're not going to get a monothematic decline in kidney function in patients. It will vary from patient to patient. You should think about managing progression factors for CKD. These progression factors might involve higher level of albuminuria, higher blood pressure, poor glycemic control, smoking, and hyperlipidemia. And these are important medical risk factors. Drug use is important. I always tell my patients, avoid nonsteroidals if you can. It's sometimes not possible. Patients who have severe osteoarthritis or rheumatoid arthritis, very difficult for them to manage without nonsteroidals. They're very effective agents for pain relief. And in these patients, I often recommend really timing the use of nonsteroidals when they're flaring up or their pain is particularly bad. In these patients, I also say, keep yourself well hydrated so you can avoid the deleterious effects of nonsteroidals. The other things make sense, right? I mean, you want to manage the blood pressure, you want to improve glycemic control, and you certainly want to tell your patients to stop smoking. If you go to the next slide, then this is a summary then for this 78-year-old man. We measured his eGFR. It was in the low 60s, a bright borderline. We asked the question, does he have risk factors? The answer is yes. He has hypertension, diabetes. He's in high risk group. He's Black American. We check his urine analysis and sediment. There were broad casts, Highland casts, a waxy cast suggesting it. Do an ultrasound. If his kidneys are small on the ultrasound, further objectively reinforces the likelihood of kidney disease. There's cortical thinning that further reinforces that. You check an albumin to creatinine ratio to see what level that is. If it's macroalbuminuria greater than 300 milligrams per gram of creatinine, that would suggest that this patient has established kidney disease and is at high risk. If it's 30 to 300, this patient is at lower risk, but certainly someone you would be worried about. Does this patient have CKD? The answer is yes. So what are the next steps you might pursue? So the keys to managing kidney disease with your patients, I would say, can be summarized in these 5 bullets. Probably one of the most important things, and perhaps one of the most challenging, is to manage blood pressure. In most patients, the goal blood pressure should be less than 130/80, and you'll need multiple agents to manage this blood pressure. Now, as you will hear in this course, patients who are diabetic with hypertension, it's a little bit more controversial with respect to how aggressive your blood pressure reduction should be. The studies such as ACCORD suggest that there isn't a tremendous benefit from aggressively lowering blood pressure in these patients below 130/80, and there may be risk because you may actually increase the risk of acute kidney injury. But on the other hand, the SPRINT trial did demonstrate that reducing a blood pressure to below 120/80 has tremendous cardiovascular benefits. And in a sub-study of SPRINT, there may actually be some renal benefits. Although, again, in a small number of patients, there were adverse events, including dizziness, syncope, and a decline in kidney function. Also, it's notable that the SPRINT trial did not include or enroll patients with type 2 diabetes. So SPRINT can't really speak to aggressive blood pressure reduction in diabetic patients. You want to manage diabetes. You want to get to hemoglobin A1C of less than 6.5 at least. Hard to do, but something to consider. And with the newer agents available, and which will be discussed by Marie McDonald later in this course, your options are much more significant nowadays rather than in the past. You want to use an ACE inhibitor or an angiotensin receptor blocker, but not both. Using both is contraindicated and doesn't seem to be effective and may be associated with increased side effects. So use either an ACE inhibitor or an ARB. For a diabetic patient with type 2 diabetes, you really ought to consider nowadays the use of an SGLT2 inhibitor in patients with type 2 diabetes. Patients with type 1 diabetes, there is no label indication for using an SGLT2 inhibitor because in patients with type 1 diabetes, there's an increased risk of ketoacidosis among patients. And as I said, it's not approved for that indication. You may also want to consider other interventions such as a low-protein diet, probably has mild benefit, and the use of statin probably has mild benefit. What about ACE inhibitors and ARBs and calcium channel blockers? Just a couple of minutes to discuss that. ACE inhibitors and ARBs have similar antiproteinuric effects, but combination of ACE inhibitors and ARBs do result in a further 20% reduction in albuminuria over and above either agent alone, but dual blockade is not recommended because randomized trials have not demonstrated an additional benefit of just with one agent, and there seem to be there's higher risk, adverse risk of acute kidney injury and hyperkalemia. Calcium channel blockers, you can use a couple of antihypertensive agents, classes, dihydropyridines, amlodipine, no effect on CKD progression, but good to manage hypertension. Dihydropyridines such as diltiazem reduces proteinuria, but not very effective for blood pressure reduction. This is a very quick schematic to show you how SGLT2 inhibitors work. They work in this part of the nephron, in the proximal in the distal part of the proximal nephron. So they work in the proximal nephron, but in the distal part, they work by reducing hemoglobin A1C because you get a glycosuric effect. They waste sodium, result in wasting of sodium, so you get an antihypertensive effect. And in fact, you get not only weight loss, but you also get a decrease in systolic blood pressure. The effects are on the kidneys. You get a hemodynamic effects, but you also get cardiac effects. There's new evidence for the use of SGLT2 inhibitors, not only in patients with diabetes and CKD, with patients with type 2 diabetes and CKD, but also potentially in patients with CKD who do not have diabetes. And that's based on the DAPA CKD study, which was terminated early. This study hasn't been published yet, but certainly keep your eyes and ears open. This will come out soon. And it suggests that there was a benefit of using SGLT2 inhibitors, even among patients who don't have diabetes, in terms of slowing progression of kidney disease. This is the randomized study that was published, the Credence study. You can look at this in the recorded views of this lecture, but it's a very, very powerful study. Suggests there was a benefit in the primary endpoint of a reduction in the composite of renal failure, doubling of serum creatinine, or death from renal or cardiovascular causes of about 30%. Very powerful study. The DAPA CKD, as I said, also demonstrated a benefit, but this study has not been published yet. It's just been, the top-line results were presented by the trial organizers, by the sponsor. So in summary, in this 78-year-old person, there's value to using a GFR equation and using albuminuria to make the diagnosis of CKD. Think about using albuminuria as a predictor of risk, but also compute the KFRE equation to get a 5-year estimate of risk of progression. Use multiple agents for blood pressure control. Not easy to treat blood pressure, but certainly you need to get the blood pressure under control. Recommendation would be less than 130/80. And among those patients without diabetes who have kidney disease who can tolerate it, more aggressive reduction in blood pressure to less than 120/80. Use ACE inhibitors and ARBs. singularly, but not in combination, no benefit of the combination, and use SGLT2 inhibitors now for patients with CKD and type 2 diabetes, especially those with modest to well-preserved GFR. And keep your eyes and ears open for the study that will be published, I'm sure in one of the top journals, demonstrating that there may be value in using SGLT2 inhibitors for treatment of patients who don't have diabetes, but who do have kidney disease. Thank you very much.
Great. So you have lots of questions. The first question is that was asked by several people is, when you say that Asians have a higher rate of CKD, does that include Central and Southern Asians or only East Asians?
I think there isn't a very big discriminator among Asians. The studies that have been published suggest East Asians, so people of Indian origin, subcontinent of India. These are studies that come from the United Kingdom, where those individuals, there's a higher risk of going on dialysis if you're an East Asian. There's some studies suggesting Chinese have a higher risk. So I don't know that one can really finally discriminate among different regions of Asia, because the studies aren't really quite there. But there does seem to be an increased risk among Asians in general.
Okay, thank you. A couple of people asks, when do you stop medications like ACE inhibitors or metformin? Do you go by the GFR or the creatinine?
So those are two separate questions. Let me answer metformin first. There is a risk of lactic acidosis, acute lactic acidosis, among patients with renal dysfunction who are being treated with metformin. So once the creatinine gets about 1.5 milligram per deciliter, somewhere between 1.5, 1.8, I tend to transition them off metformin because of this higher risk of lactic acidosis. With respect to ACE inhibitors, a paper published several years ago by Ho et al. From China in the New England Journal of Medicine suggested that even among patients who have more advanced renal dysfunction, GFRs between 15 to 30, so stage 4 CKD, there is a benefit of ACE inhibitors and angiotensin receptor blockers. They tested only ACE inhibitors, but I would argue that the effect is probably similar given the mechanism of these drugs. There is a benefit of continuing to slow progression of kidney disease. So I tend not to stop ACE inhibitors, ARBs, if renal function continues to decline down to 15. And in fact, there are many patients I keep on ACE inhibitors while they're still, even after they've initiated dialysis, because there is some evidence suggesting that you preserve renal function to a greater degree, residual renal function, if you keep these patients on renal angiotensin blockade. So the answer is different between these two classes of agents.
Great. What would you recommend as minimum tests for inpatient clinicians who incidentally find a chronically raised creatinine for an admitted patient?
I think David Leaf addressed this. I think it's critical to do a good history and physical examination and look at what's going on in that patient. Sometimes you'll see patients in-house who have an elevated creatinine, and it's actually worth going back to seeing what their creatinine or kidney function was prior to admission. If this is a patient who's been very stable for many years, I don't think you need to do a workup in those patients. Yes, almost everybody at our hospital that comes in gets a blood chemistry panel and gets a CBC and so on. But in general, I would say trying to do a full scale workup of someone should really be determined by the tempo of or change in kidney function. But let's assume if the patient does have newly discovered abnormal renal function, and the history suggests that the patient is either unaware of it or that it hasn't been detected before, what you're looking for is really how recent is it? Because if it's very recent, it could be acute kidney injury, and you'll be looking for risk factors for acute kidney injury, new medications, other medical issues that are going on, worsen cardiac function, and so on. So I think it really all depends on the clinical situation. I wouldn't say there is a cookie cutter approach to every single person with an elevated creatinine. Otherwise, you'd be doing tons and tons of ultrasounds and other forms of measurement that may actually not be indicated.
Okay. For a patient admitted to a hospital with CKD who was not on one of them, is it a good idea to start ACE or ARB in patients and discharge them with outpatient follow-up?
Yeah, I think that while the penetration of the use of renin-angiotensin blockades is really good, it's not perfect. And so we should always keep an eye out for people with reduced kidney function who might benefit from renin-angiotensin blockade. The National Kidney Foundation guidelines suggest that really the people who benefit most from these agents are individuals with albuminuria. And so it's actually worth checking if you have someone with chronic kidney disease who doesn't have any other risk factors like diabetes or hypertension, whether they have albuminuria. And you can do that by, obviously, you can check a dipstick, but that'll pick up more significant levels of albuminuria, but you can do a urine albumin to creatinine ratio spot check. If there is albuminuria, then they might benefit from an ACE or ARB. I wouldn't want you to go ahead and take normotensive patients who don't have risk factors, who are elderly, and start everybody on an ACE or an ARB, because I think the data isn't there that there's benefit in those patients. So I'm not arguing that everybody should be treated. You have to really think about who might benefit. And the presence of albuminuria, the presence of risk factors like diabetes or hypertension are important telltale indicators of patients who might benefit from these agents.
Great. Thanks. There are more questions, but I think the time's up.